So the appendage closure now is important for two reasons. One is for stroke prevention. And even if you don't change the AFib, if the patient stays in AFib, if the appendage is closed, probably 97 chances out of 100 they won't have an AFib stroke. And they don't have to take blood thinners. Secondly, if you're doing some procedure for AFib, you're going to get a better result. In other words, lower incidence of AFib if you also close the appendage. One of the problems that the patients have with catheter ablation is most of them are still on a blood thinner. They don't like that. But with the surgical approach, we have the opportunity to close the appendage. If the appendage is closed, I don't believe these patients should be on blood thinner, unless they're on it for some other reason. But if they're only on the blood thinner because they have AFib, you close the appendage, I stop it. Now, we don't have a big enough trial to prove that the stroke rate is lower, because we need about 1,000 patients, because the incidence of stroke is only 2-3% per year. So you need a very big series. But in my own cases today, if we close the appendage, no more blood thinner. How about you?
No blood thinners.
No
so
blood
that is the
thinner.
advantage of our procedure.
And that's what the patients want.
Exactly.
They want to
Number
be off
one
the blood thinner.
reason.
Maybe more important than stopping their AFib is to get off blood thinner, I think. At least in the United States. Same here.
It's the same.
In general, today in the United States, patients are referred for surgical closure of the appendage if the catheter approach is not a good idea in that patient. For example, in the United States, per protocol, with the Watchman device, the patient should stay on Coumadin for 6 to 8 to 10 weeks after the procedure. So if a patient says, I absolutely cannot take blood thinner, then they really shouldn't have the Watchman, and then they go to surgical approach. Secondly, in some patients, they do their homework, and they read about the Watchman, and they compare that to the surgical closure, and they say, I'd rather have surgical closure. The Watchman device was presented to the FDA at least 3 times in the United States and failed because the results were not good. The latest report that came out just within the last year showed a mortality rate, death rate, at 1 year after Watchman of 9%. And they said, well, these are sick patients. If we had 9% mortality at 1 year, it'd be terrible. The Watchman device rarely closes the appendage completely. There are almost always leaks. And the way they got it through the FDA in the United States is they eliminated all the small leaks. And they only counted the big leaks. I've had occasion to see a patient who had a Watchman device and then 2 years later had to have mitral valve surgery. And you look at the Watchman device surgically from 2 years before. No closure at all. No closure, no ingrowth of tissue, nothing.
No endothelial coverage.
No.
Nothing. Oh, really?
I believe it's best to start where you still have an incision between the ribs, where the surgeon with loops on, surgical loops, can see the pericardium, can open the pericardium, can see the appendage, can manipulate the appendage under direct vision or with the scope. You still need the scope. One, you need the light, but two, part of the procedure you still do through the scope. And then the possibility is, if the surgeon's comfortable, they can slowly evolve to where you are, where you don't need the incision at all. But I think starting out, it's a little bit easier for the surgeon. As far as the patient's concerned, I haven't seen any difference in recovery, whether we use that incision or not.